Thank you, Premier. Certainly, we've seen a significant increase in the so-called mystery cases or cases of unknown acquisition. The graph here really represents the fact that we've gone into a second wave with an increasing number of overall cases, and right through it there's been about 1 in 5 or 20% of cases that are mystery cases or cases of unknown acquisition. With every case that we have, we do go through a detailed interview process, and you'll have heard me talk about incubation period. So that's the period of time from being potentially exposed to the virus to developing symptoms, and it can be up to 14 days. So someone can be exposed, but they won't become unwell until 2 weeks later. But actually the majority of people will develop symptoms in the first week, usually around the 5 or 6 day mark. So for our contact tracers in our team who do the interviews, there is a detailed process of not just working out who your close contacts are when you're infectious, where you've been, who you've been in close contact with, but also the acquisition period, or that period of time before you become symptomatic. So we do go into a really detailed process of trying to find out where people have been in the days prior to becoming unwell and the people that they've been in close contact with, because we're trying to work out where they got it from. And for 1 in 5 cases, we can't determine that. And that'll be for a number of reasons. They just simply don't have anyone else in their household who's been unwell. They can't identify anyone in their workplace who's been unwell. And the places that they nominate don't have existing cases, clusters, outbreaks. And so we can't determine absolutely where they've got it from. But of course, we know that there are other opportunities that people can pick it up. Sometimes they won't recall a close contact, and sometimes it might be that they've had a more casual contact, and for those people they can't identify where they've been or with whom they've been, but they've probably picked it up there. What is notable is that it has plateaued in the last week or so. That's related to a plateauing of our overall cases, but our so-called mystery cases have plateaued as well. If you look at this graph, it's a breakdown of metro and regional local government areas. For metro areas, it's about 20% that are so-called mystery cases. For regional Victoria, it's more like 13%. The reason for that is obviously we're linking more to known travel to Melbourne. It becomes easier to identify that someone has picked it up in a particular spot in Melbourne, because they are recalling that, they are talking about the places that they've been to or the people they visited in Melbourne. But the 13% is still of concern, because it does represent those mystery cases that might have been picked up locally in those local government areas, and the ones that are represented most strongly in the regions are the ones that the Premier's talked about as being of concern. So the Greater Geelong area, Greater Bendigo, Ballarat, and even Mitchell Shire, although Mitchell Shire has stabilised over time. And there is a variation in the number of, or the proportion of people who we say are mystery cases in those local government areas. When there's only 1 or 2 cases, then it might be 100% who are known cases where the acquisition is known, or it might be 0%. So when the numbers are very small, those proportions can vary a great deal. And in terms of the age groups, obviously there's a real significant representation for that young age group of 20 to 29-year-olds. For the older populations, I mean, it's all representative of the kind of proportions by age group in a normal population, but there is a bit of an overrepresentation of youth and an underrepresentation of the very oldest and the very youngest, and that's largely because we're linking a lot of our elderly cases to known outbreaks. They're known to be in residential aged care. They're known to be in hospital clusters or outbreaks as well. And for the very youngest group, again, linked to family members who are linked to workplaces or are linked to childcare or school settings when they were open. But over a quarter in that 20 to 29 age group. That does represent the majority age group for our cases overall, but it's certainly also overrepresented in our mystery cases. And they're probably more mobile. They do more of the essential activities for a household. They're obviously more engaged in the workforce, and so there are more opportunities for that age group to become infected and to be exposed to transmission. Happy to take questions.
Does that breakdown apply for healthcare workers? Like, is it the same? Is it 1 in 5 with healthcare workers? Is it lower, higher?
So healthcare workers, we're still working through their acquisition. There will be data next week that we're going to present on both the particular workforces that are mostly represented in our healthcare worker cases, but to try and dig down to exactly where they've acquired it. But I imagine there'll be a similar proportion of so-called mystery cases. Although healthcare workers, as we know, they're involved in outbreaks, they are involved in direct care, and so there are probably going to be more that get resolved in terms of where it's been picked up, or that it's been picked up from a known case. But often, it'll be a question of which known case or determining the exact transmission that might have occurred for health workers that is the challenge.
And with people working...
The man in his 20s who's died, was he linked to a known cluster, or was he a mystery?
I don't have any further details on that, gentleman.
Do you have a strategy for trying to drive down the increase in these mystery cases?
Well, really the strategy is stage 4 restrictions. They will work both for cases where it's known close contacts, but it's obviously a really important intervention for community transmission where unknown transmission occurs. The fewer opportunities that people have by virtue of the stage 4 restrictions, then the less community transmission will occur, and we'll see that new daily cases of community or unknown cases come down over time.
Do you know if aged care workers are still working across more than one aged care home? And I wonder if you know if that's happening with nurses across hospitals as well.
Look, it's probably for the Commonwealth and the Victorian Aged Care Response Centre to answer that specifically. I know that there are some constraints in terms of being able to say you can only work in a single setting and no other settings whatsoever. But I know that for public sector aged care in particular, there's been a commitment and a policy directive to make sure that almost everyone, if not everyone, is working in a single facility and not across facilities.
And can I just ask if people are still going to work in aged care homes while they're sick? We get lots of people saying, my wife is forced to go to work in the nursing home while she has a runny nose. Is that still happening?
It is still happening. It's happening across workplaces. The challenge, and we've reinforced it at almost every press conference, is that you have to isolate with the first symptoms. But we know that people are challenged either by dismissing those symptoms because it's just a scratchy throat, or it's just the beginning of a cough or the beginning of a runny nose. And so when we interview those newly confirmed cases, including some who are working in healthcare and some who are working in aged care, of course, they represent the general population who also sometimes say, oh yeah, I was symptomatic for 24 hours, or I had 2 days before I isolated and got my diagnosis.
How is Geelong, Bendigo and Ballarat going? Obviously, you both talked about the need for testing there. It's only 24 hours or so in. Has there been a big take-up?
There's been a reasonable take-up. I'm pleased that people are going to come forward. We'll see those results over the next 24, 48 hours, and we will analyse those newly confirmed cases that we'll see there. I think there are positive signs in Geelong in terms of stabilisation of some of those large outbreaks. As a proportion of total cases, they don't have, I think they're at 13% in terms of the mystery cases. Ballarat, Bendigo, relatively smaller numbers. It becomes a bit easier to manage, but we need to dig down to each and every one of those cases to understand how much is mystery transmission and make sure that we can get on top of the known cases.
What's the proportion between mystery and clusters in those three regionals?
I'd have to come back to you for those individual local government areas.
But is it swayed in one favour? Like,
Yeah, look, it does depend on the particular local government area. Some of them, with smaller numbers, have a greater proportion that are unknown. Others have a greater proportion that are known to be linked to outbreaks.
On mystery cases, London, there's some information out of London that they've got around, or they thought they had around 374,000 asymptomatic cases. When you look at Melbourne, that may put our number around 200,000. How many of those mystery cases do you have to, for lack of a better phrase, write off on the fact that they've come into contact with asymptomatic cases?
The whole question about asymptomatic cases and how much they contribute to transmission is a vexed issue. I think the evidence is suggesting that truly asymptomatic people who never develop symptoms, probably don't contribute much to transmission at all. What we're concerned about are people who have pre-symptomatic illness. So in the 2 days before you develop your first symptoms, they are known to be infectious, and they can be highly infectious just before they develop symptoms. And so some of those mystery cases will absolutely have been exposed to someone who's pre-symptomatic, and therefore they can't identify, when we're asking them, have you been in contact with someone who's been unwell, they can't identify that person because they have been pre-symptomatic. So, you know, that's one of the really key elements about wearing a mask, that for all of us who are wearing a mask, when we're pre-symptomatic, if we're developing illness, we'll be exposing others much less by virtue of wearing that mask, and it's not just for people who've got symptoms.
With the amount of testing you're doing, how much do you think that's actually picking up? What are you assuming? Is that 50% of what's really out there, 80%?
I think it's close to 80%, 70, 80%. Very early days in Australia, it was probably estimated at 80 to 90% because we could link more to international travel. But with 7,000, 8,000 active cases, it becomes harder to know the ones that aren't being identified. But I think it's the great majority. Obviously, we continue to encourage everyone who develops symptoms to test. We know that flu is at record low levels across Australia. It makes it more likely that if you've got flu-like symptoms that it'll be coronavirus. Of course, there are other viruses circulating, but people need to think about their runny nose and their sore throat and their cough, change in taste, change in smell, as coronavirus until proven otherwise, and they need to isolate for that reason, and they need to test for that reason.
So community transmission cases, these community transmission cases you said are stabilising. So we're 12 days into stage 4, 9 days into the industry shutdown. Is it doing what you were hoping it was going to do when you look at community transmission?
I think it's still to play out. I think stage 4 restrictions are only really going to show in the numbers over the next few days. These are still the effects of mask wearing and stage 3 restrictions. So I think that's encouraging that we've turned the corner with those interventions, and that we should see a further driving down of transmission with the stage 4 restrictions. So yeah, it's going in the right direction. I'm very confident we've seen the peak, but it's got to come down quickly.
What are you expecting to see with the death rate over the next week, and when do you think that might start to come down?
Well, I think because we've seen a stabilisation of the number of active cases now, it's essentially levelled off. Then I think we'll see a levelling off of hospitalisations for community cases in the next couple of weeks, and the same for deaths. If we can drive numbers down from here on in, knowing what we know about when people develop their worst symptoms and are at greatest risk of dying, we should see a stabilisation of deaths in the next couple of weeks. Of course, we're all concerned about the significant number of active aged care cases, over 2,000, and they are most at risk, and they're at most at risk of dying. So we also have to drive those numbers down as well.
Just on compliance. Sorry, you go,
That's
Gav.
okay.
You go.
The Acting Chief Medical Officer, Paul Kelly, has said today that he agrees the number of cases has overwhelmed Victoria's contact tracing capacity. Do you agree with that, and do you think that's been a big problem for Victoria's contact tracing?
As I've said before, when cases are at 50 a day or 50 a week, everyone in the world was doing contact tracing to the nth degree, finding people very quickly, doing all of their acquisition, getting all of the details for every single case. When you've got 300, 400 cases a day. That stretches any system anywhere in the world, and a number of countries just stopped contact tracing. They just had a general message to people: if you've got symptoms, isolate at home, try and get your test result. We're doing much, much better than a whole bunch of countries that essentially gave up on contact tracing. We are still actively contact tracing every single case that comes in. But there's no question that when you have hundreds of cases a day, because it stretches the testing capacity, because it stretches the couriering of swabs to the path lab, and because it stretches the notifications into the department, as well as the contact tracing that's done, it pushes all of those things out by a few hours, and that is really critical in following people up. The fact that we can now interview every single case who picks up the phone or answers their door in 24 hours is hugely encouraging, and the fact that we can get a message out and knock on the door of close contacts within 48 hours, 100% virtually, is also very encouraging. But there's no question that 7,000, 8,000 active cases is a challenge.
Can we see some of those numbers? Does it make a difference, and are those numbers there? Stephen Duckett was basically saying the numbers are there. For some reason, we're not getting a look at them. Are the numbers there? Can we see them?
The numbers are being worked through. Our database can extract some of those performance measures, if you like. They're not all in our control. Some of them that relate to courier time to labs or lab processing time are not our data. But I fully support getting some of those metrics out, and I think it would be reassuring for people to see how much contact tracing that we're doing and the kind of timeliness of it nowadays.
How are we going with test wait times?
It's under 2 days. It's 1.6, 1.7 days.
The average?
The average.
So there are some people still waiting up to 4 or 5 days for their results.
There will be some people who wait 4 or 5 days for their results. I ask them to be patient with those results. The labs are, they're processing 20, 25,000 tests a day. And people who still have symptoms should be isolating regardless. There are some people who will test negative who actually have coronavirus who should still be isolating until they are well. It's frustrating not to be able to go back to work. It's frustrating not to get that negative result for your own reassurance. But again, the great majority of people will get that result in 48 hours.
Ramya, on compliance, we obviously heard about the great number of mystery cases are young people.
Whichever order you... Brett first. Brett, did you mean peak of community transmission or overall, and how pleasing is that?
Oh, same thing. Peak overall will be likely the peak of community transmission. It would be terrific if it's true. I'm very confident it's true, but we always watch the numbers every day. Today's a bigger number than yesterday, and we don't know what tomorrow will necessarily bring, but the trend is definitely downwards. The 5-day trend, the 7-day trend indicates that the peak was probably 4 or 5 days ago, and that we'll continue to see lower numbers overall as a trend from here on in.
So what's your message for Victorians then?
Keep at it. I mean, this is a long haul. We know that numbers are heading down, but we couldn't conceive of opening up with 200 cases a day. I don't think we could do it with 100 cases a day. We really need to drive numbers down to the lowest possible level, including zero, to give us the greatest confidence that we can ease restrictions and not see an upsurge that would have us heading back to restrictions again. We have to get to a point where it's entirely manageable, if not completely snuffed out.
And to get there, you're going to have to get a message out to everyone. The ABC reporting yesterday that both federal and state governments looked like they were using Google Translate to get messages into the right language. Do you think we're reaching enough people who don't read the newspaper and don't speak English as a first language?
Yeah, I will say, I think engagement with culturally and linguistically diverse communities is central to how we proceed from here on in. I am aware that we're using multiple channels and multiple media. I think it's an ongoing effort that we need to make, and we absolutely... We always need to do more. So no, we're not doing enough. I think we always need to do more because it's a really significant challenge, and this is a community, broadly speaking, communities that will need different information given to them in different ways, and fed back to us in ways in terms of what their needs are and the things that motivate and engage them. And so I think we need to be as creative as possible. I think the Burnett Institute was absolutely right in terms of saying this is central to the response right through. But it's a continued effort that we need to make, and I know that a lot of people from families where someone has a different country of origin will go to that country of origin for information, and a lot of that information is absolutely incorrect. A lot of it is directed misinformation, and that is entirely unhelpful in terms of people doing the right thing. So, yeah.
And that'd be highly represented in that 20 to 29 of mystery cases, wouldn't they?
Yeah, absolutely. So culturally and linguistically diverse communities are the youth cohort within those communities are absolutely the target. And that's not traditional media. We've got traditional media for a bunch of reasons. We've got campaign-style materials for a bunch of reasons. But we also need local champions, local youth, community leaders, but other individuals that people look up to or that people are influenced by who aren't necessarily establishment leaders.
Brett, putting aside what sort of happened in the hotels, looking at the people who became infected, is there indication that they didn't self-isolate properly or how that spread into the wider community once they were infected?
Look, it's not clear. Across the board, we have people who self-isolate well, others who don't do it so well, others who don't do it for a bunch of reasons that are not wanton or malicious, that are about lack of understanding or other pressures to not self-isolate. But in terms of the specific circumstances out of hotel quarantine, I couldn't tell you.
But we're being told that some people at hospitals that are getting tested have been asked to self-administer the test. What are the reasons for that?
So there are some individuals who find it very uncomfortable or who are very anxious about having a test done by a albeit trained individual, and if it can facilitate that test getting done for somebody to do it themselves, especially the nasal test, the deep nasal swab as we call it, then we should have that available as an option rather than not have the test done or have someone fight the test. That should never happen. And so if someone can do the test themselves, find that point of comfort to be able to get a decent swab, then that's a useful option for them.
So
Is
it's
the
not about
automatic-
staff not having sufficient PPE, for example?
No, it's not about staff not having sufficient PPE, but it doesn't require staff to have PPE. If someone's self-administering the test, they can obviously do it on their own away from others, and the test can then be picked up without a risk of that aerosol generating procedure happening with health staff around.
Is the automatic rule for anyone that gets a test still to self-isolate?
Anyone symptomatic who gets a test absolutely needs to
But
self-isolate.
asymptomatic?
Asymptomatic individuals do not have to isolate because they're like you and me. We're not self-isolating all of the time. The fact that we have a test doesn't change the fact that we're someone without symptoms. If we are a close contact, then we are always self-isolating. So someone who's a close contact is told to quarantine until they've done their 14 days.
Just to be clear, if you wouldn't mind, I've been contacted by the owner of an abattoir who's been offered testing by the government to his employees, and in the documentation it says they don't need to isolate. Now, he was just a bit confused from him because, there's been this big messaging around everyone must self-isolate when tested. So if the government, and you're saying anyone that's asymptomatic gets a test, they do not need to isolate. Is that right?
If they're not a close contact, yeah. If they haven't been told to self-isolate, quarantine, because they're a close contact, because we know that they need to do a 14-day quarantine period, then no, they don't need to self-isolate if they have no symptoms.
Can I ask the Premier, if I may, let's talk football. So,
Just before we do that, can we do the
We
peak?
can.
Can we do peak for the Premier first before we do that?